Good evening. Everyone can hear me okay? My name is Nelson Branco. I'm a primary care pediatrician. I work and practice at Tamalpais Pediatrics here in Larkspur and also in Novato. As a primary care pediatrician, vaccines are one of the big parts of our practice. It's one of the most important things that we do. I have gotten very interested in vaccines and in promoting vaccination over the past 10 years. I've worked closely with Dr. Willis on promoting vaccination and on debunking some of the myths and some of the misinformation that's out there about vaccines. I thought that I would use my time in an overview of the vaccine schedule. One of the things that I think Dr. Willis will talk about is how many parents and others who are concerned about vaccines are concerned about too many vaccines. And so I thought it would be interesting for us to look at the number of vaccines that are actually given and how they've been introduced and why they've been introduced into the vaccine schedule. So I sort of went from 1950 to 2018. Many of you may know the first recorded vaccine is smallpox, which was invented in 1796 by Edward Jenner. You notice that milkmaids who were exposed to cowpox, which is a related virus to the smallpox, had a much milder disease. And so he developed a method of inoculating people with smallpox by taking the pus from the blisters of one person and putting them under the skin of the arm of another person, and it worked. In the late 1940s, we had lots of advances in science, and so we were able to develop some new vaccines and in large-scale vaccine development, distribute them to the population. They were giving smallpox and DTP, the diphtheria, tetanus, pertussis vaccine. I have some info about some of the commonly given vaccines and why we still give them. So in the 20s, diphtheria in the US caused 100,000 to 200,000 cases per year and 13 to 15,000 deaths. The number of cases rapidly declined. You'll often hear people talk about how sanitation is responsible for the decline in infectious diseases. Diphtheria is one where that may actually be the case. The number of cases went down as far as 19,000 in 1945, and then with the widespread use of the vaccine, there was a much more rapid decline. Tetanus is a similar story. There's been a decline in the mortality due to tetanus since the early 1900s, and a lot of that was increased sanitation, movement from rural areas to urban areas, but again, a much more rapid decline since the mid-1940s. And then pertussis, which is something that we still talk about today, lots of cases of whooping cough still. Partially because the vaccine has changed over the years and we use a different vaccine now than what was originally developed, which may or may not be as long-lasting, but also the pertussis disease itself doesn't confer lifetime immunity. And so even in the days pre-vaccine, if you had pertussis 3 or 4 years later, you were susceptible once again to getting the disease. And
so they're all bacteria, right?
So these are all bacteria, yeah. Except for the smallpox, sorry. But the DTP, those are all bacteria. In the late 1950s, the polio vaccine, and this is something that many of us remember the pictures of iron lungs. I think there was an article recently about the last iron lung in the U.S. is one gentleman who is now, I think, in his 80s, who is still in an iron lung from polio in the 50s and is having trouble getting parts for his final iron lung in existence in the U.S. So the OPV, Jonas Salk invented this. It was licensed in 1955, and he's on postage stamps and was lauded for this. Finally, kids could go swimming. Lots of folks remember the sugar cube with the polio vaccine. While polio was endemic in the U.S., in 1979 was the last transmission of wild poliovirus in the U.S., the Western Hemisphere, 1991. It was eradicated, and then there's a global polio eradication program that the goal of which was to eradicate polio across the globe by 2020. And that has been, a goal that I've seen in my career has been moving. There have been some anti-vaccine movements in Pakistan and Nigeria that have sort of slowed things down. And I think there was an outbreak, Matt, you may remember, in South America somewhere this year. I think it was Ecuador, Peru, maybe Peru, that there were some cases once again. But in 2012, which is the last year I have the numbers for, there are only 233 confirmed cases. So we're getting there. We're close on eradication of polio. In the late 1960s, they added measles, mumps, and rubella as 3 separate vaccines. Measles is one that we pay a lot of attention to because of how contagious measles is and also how deadly it can be. Before the vaccine, nearly everyone got measles. By the time they were 15, the estimates are 3 to 4 million people in the US were infected every year. 400 to 500 died per year, 48,000 hospitalized, and 1,000 developed encephalitis. It was declared eliminated, which means no new measles cases for 12 months in the US in 2000. And at this point, all of the measles cases that we see in the US are imported cases. And so in every case of a measles outbreak, the Disneyland measles outbreak being the most widely known, there's a traveler from overseas who imports measles into the country, and then susceptible children and adults will get measles. There actually was a measles death in Washington State associated with that outbreak. Mumps, before mumps, 186,000 cases a year, but likely much more. Folks didn't often report mumps. And since the vaccine, more than 99% decrease. Mumps is probably the least effective of the 3 vaccine, of the 3 components of this vaccine, and so we do still see mumps outbreaks, often associated with places where people congregate. And so there was a mumps outbreak often on college campuses. There was a case of mumps at Berkeley last year. There have been cases of mumps in Hasidic communities where the young men all congregate. And actually a case of mumps in San Anselmo several years ago in a child, a school-age child. For rubella, Hank, you will appreciate, congenital rubella syndrome is the reason why we vaccinate against rubella or German measles. There was an outbreak or an epidemic of rubella in 1964-65 that resulted in 12.5 million cases of rubella infection and about 20,000 newborns with congenital rubella syndrome. And congenital rubella is something that I've never seen in my career, hope never to see. It's a disease that affects nearly every organ system: developmental delay, blindness, deafness, hepatitis, liver issues, etc.
Rubella is German measles?
German measles, yeah.
I was going to ask if there were 2 kinds, if there's more than 1 kind of measles.
Mm-hmm. Yeah. In the 1970s, smallpox was declared eradicated, and in 1972 we stopped vaccinating against smallpox. The measles, mumps, and rubella vaccines were combined into the MMR, and so we're left with 3 vaccines on the schedule in the 1970s. For what it's worth, this is what I got when I was an infant because I just missed the smallpox vaccine. The next vaccine to be added to the routine schedule wasn't until 1985 when the Hib vaccine was developed and added. And so in the early 1980s, there were about 20,000 cases a year of Haemophilus influenzae. So Hib stands for Haemophilus influenzae, which is a bacteria that causes meningitis. It causes epiglottitis, which is an infection in the throat and the top of the airway that can lead to issues in the airway. I'm sure you've seen lots of that. And then also cellulitis, and so skin infections. This vaccine the incidence of Hib disease, what's called invasive Hib disease, which is meningitis, skin infections, epiglottitis, or the throat infection, began to decline dramatically in the late 1980s and is declined by 99% related to the pre-vaccine era. This is a vaccine that was introduced when I was training, when I was in medical school. And pediatricians who have been in practice for 3, 4, 5 years longer than I have will talk about going to the emergency room to evaluate febrile infants, infants with croup, which is a viral illness that causes funny noise when you breathe, stridor. Epiglottitis also causes stridor. And so in those days, you never knew if it was this very significant, serious bacterial disease or just croup that's going to get better with a couple of days. And they took care of lots of kids with meningitis, did lots of spinal taps and antibiotics and x-rays. I have seen one case of Hib epiglottitis in my career, and I've seen one case of Hib meningitis in my career. Both of those were in unimmunized kids from overseas. And so, this vaccine made a dramatic difference in those diseases. 1994 to 1995, the hepatitis B vaccine was added as a routine vaccine. Before that, it was for high-risk groups, and so for those of us in healthcare, for injection drug users, for men who have sex with men, and for folks with blood diseases and other medical issues, they were recommended to get the hepatitis B vaccine. That didn't really make much of a difference in the incidence of hepatitis B, and so it was added to the routine schedule for vaccines. The reason for that is because hepatitis B, in addition to being something that you get through blood and body fluids, is also perinatal transmission. So during the birth process, you can get it from your mom. There also were many cases of hepatitis B in children where there was no known contact. There was no real exposure. There was no identified exposure. Household contact was also a risk. If hepatitis B was acquired at birth, it created a much higher risk of chronic hepatitis B, so you couldn't get rid of it, and it created a much higher risk of liver cancer. And so hepatitis B was actually our first cancer vaccine. So and so hepatitis B is given once in the first year of life, but it's 3 doses. And so you give 3 doses, one at birth, one usually at 2 months, and another at 6 to 9 months.
You get one later because you're a healthcare provider. You have to get 2?
You would have to do 3, yeah. It's there is a 2-dose adult series of hepatitis B, but those of us who got it when we were training in medical school got the 3 doses, and some of us got 4 and 5 doses because we didn't respond or didn't have records. So 1995 is when the vaccine schedule was first published. So the vaccines I've talked about, hepatitis B, the DTP, Haemophilus, polio, and MMR. In 1996, the Varicella vaccine was added. This is about when they started to actually publish yearly vaccine schedules, and you'll see as time goes on, it becomes more complicated and with a lot more details. The chickenpox vaccine, or the varicella vaccine, I apologize, I didn't bring my numbers, but in the early days of my career, so now 20 years ago, a little over 20 years ago, we saw lots of chickenpox. And we saw many kids who developed chickenpox and cellulitis. I would hospitalize at least 1 or 2 kids a month with chickenpox and pneumonia, or chickenpox and cellulitis. It really was the secondary infections. It was a widespread disease. Almost everyone got chickenpox or was exposed to chickenpox. And in children, it was generally a pretty benign disease, but there were thousands of kids who were hospitalized. And I forget the number off the top of my head, but some number over 100 who died of complications of chickenpox. And then, of course, there's the shingles that you get later on, which nobody really appreciates. With the chickenpox vaccine, the rate of shingles is very, very low, next to zero. And when we see a case of chickenpox in the office now, I can assure you that more than one pediatrician looks at it because it's hard to tell. The vaccine is not 100% at preventing chickenpox. It is 100% at keeping you out of the hospital and preventing all the complications and the secondary infections. But when you do get chickenpox, you don't share it with anyone else, so it's very much less contagious. And the chickenpox is very mild. It really is difficult to tell that it's chickenpox at all. In 1998, the polio virus switched from being an oral polio to an injectable polio. And so some number of kids, 1 in 6 million, who would get the oral polio virus would actually develop polio. Once the number of cases of polio in the US dropped below 1 in 6 million, it became riskier to have the vaccine than to not have the vaccine, and so we transitioned to the injectable polio, which was a little less effective, but did not have that risk of the vaccine-associated polio. And so that was a change, and then we added a rotavirus vaccine. This rotavirus vaccine bears talking about because it only lasted for about a year on the schedule. And this rotavirus vaccine was both a success and a failure. It was a success because it actually successfully prevented cases of rotavirus, which is a virus that causes a diarrheal illness. In children, about 95% of kids by the age of 5 would have been exposed to rotavirus. Many thousands admitted to the hospital with dehydration, and then of course some deaths. In the world, if you're looking at internationally, it's the leading cause of death in kids internationally. This vaccine was a failure in that it was associated with a complication called intussusception, where there's an inflammation in the intestine telescopes in on itself, it causes inflammation and pain, and often those children will need surgery or a radiologic procedure to treat that. And what happened with this vaccine is that it actually increased the risk of intussusception, but it wasn't discovered until after the vaccine had been recommended and was out in use. And it was through a system called the VAERS system, the Vaccine Adverse Event Reporting System, that increased incidence was found, because VAERS is designed so that physicians, family members, patients, anyone can call and say, I got a vaccine and something happened. And VAERS collects that data after the vaccine is out and being used and looks for patterns. And in this case, enough children had developed intussusception, parents and physicians called and said, hey, I had a patient who had this rotavirus vaccine, and a month later they were hospitalized with intussusception, that it was shown to be a risk factor, and so the vaccine was taken off the market. It comes back, so you'll see it again in a couple of years in a different form, but I consider this not only sort of a failure of a vaccine that actually caused a significant side effect, but also a real success in that it showed that our monitoring system, our reporting system really worked. And if you compare vaccines to other medications and treatments that we use, we actually do much more both active and passive surveillance of vaccines and looking for side effects than a lot of other medications. It took a lot more doses of Celexa before not Celexa, but Cerebrex. Is that it? Celebrex, before we figured out that it caused heart attacks. Yeah, you would know. Oh, you're too young for Celebrex.
I was not. I'm not too young for Vioxx.
Yeah, and Vioxx, there you go. Hepatitis A was added to the vaccine schedule in 2000. You see my note there, rotavirus vaccine was removed from the schedule. Hepatitis A is another interesting one in that was added to the schedule initially only in high-risk areas. And so they would identify states and regions that had a high risk of hepatitis A, and children who lived in those states were, hepatitis A was recommended at age 2. At that time, I was practicing on the Navajo Reservation in New Mexico, and Native Americans had very high rates of hepatitis A, and so we would give this vaccine. I came to California, and initially it wasn't recommended, but then the rates of hepatitis A in all these high-risk states dropped to the point where it was equal to the states where it was low risk. And so the decision was, do we stop giving it in high-risk areas? Well, no. Well, it's unfair to give it to them and to not to give it to people in low-risk areas because the risk is the same. And so then it became a universal recommendation. And so we started doing it everywhere. Why do we give it to kids? Because hepatitis A is fecal oral, and so you don't wash your hands, and the virus gets into your food or water, and that's how it's transmitted. Now we hear about hepatitis A when the Costco berry outbreak happens, or there was a hepatitis A sushi outbreak associated with a restaurant in San Rafael, or a taqueria in San Jose, or a Jamba Juice in San Jose, and so it's often foodborne and travel. And so lots of other countries still have endemic hepatitis A. Children usually have pretty mild disease, often asymptomatic disease. Adults are much more likely to have liver failure. And so, but children are always implicated in the outbreaks. And so very high risk if you have contact with children. And so getting rid of it in in kids means that adults are protected. So that's why we do hepatitis A for all kids. In 2002, influenza vaccine was added, and the pneumococcal vaccine. Pneumococcal vaccine is one that is particularly interesting to me. When I worked on the Navajo Reservation 1998 to 2001, I was part of the studies of the effectiveness of pneumococcal vaccine. The Navajo and certain other Athabascans have an increased risk of pneumococcus. Pneumococcus is a bacteria that causes meningitis, blood infections, pneumonia, and ear infections. And all of those things were more common in those groups. The pneumococcal vaccine prevents all of those things. It was designed to prevent meningitis, but we saw lots of halo effect and less ear infections, less blood infections, et cetera. My patients in this study, some of them I would send them across the way to the Johns Hopkins study room, and they would get randomized to get either a vaccine or a placebo, and it was only unknown for about 3 or 4 months because I knew exactly who had gotten the vaccine because I wasn't seeing them for ear infections over and over again. I wasn't seeing them for pneumonia or for blood infections. I've taken care of lots of kids with pneumococcal meningitis. I'm very happy to say that hasn't happened in 15 or 16 years, and I really never want to do that again. The pneumococcal vaccine is also one of those that I think it's underappreciated how much our practice changes based on vaccines. And Dr. Levin and I can both attest that in the early days of the pneumococcal vaccine, when we had a febrile infant or toddler, they would get a blood test, they would get a urine test, and often they would get a spinal tap. And in the early days of my career, 20 years ago, before this vaccine was really in widespread use, I would do spinal taps, 2-3 times a week in the wintertime at least. And I have not done a spinal tap in, I'm happy to say, probably 7 or 8 years at this point. It just has made invasive bacterial disease so much less common that we really have changed the way we practice and what we do. We use far fewer antibiotics, we do far fewer blood tests and spinal taps and urine tests, and we put many fewer kids in the hospital, a lot fewer x-rays as well. Yeah.
Another indication is for people who've had splenectomies.
Mm-hmm.
There was a rather famous case where a woman trauma had her spleen out, was not vaccinated, 6 months later comes in and dies of pneumococcal pneumonia and a huge lawsuit. So
Yeah.
That's an indication for why don't we, vaccinate adults to prevent them from getting it in the first place.
So now
splenectomy is one.
Yeah, so splenectomy, immune deficiencies is a reason not only for a pneumococcal vaccine, but meningococcal vaccine, and in younger kids, Hib vaccine if they're asplenic. There actually is now a recommendation for a conjugate pneumococcal vaccine in adults. And so the new...
Advertised on TV.
well, of course,
That's true.
because how are they going to get you? They got to let you know because you don't go to the doctor every year. But that it's for that reason is that as you get older, your risk of pneumococcus goes up. The interesting thing about this vaccine, so we had a pneumococcal vaccine for many years. It was the 23-valent pneumococcal vaccine. Without getting too far into the science, it just wasn't effective in young kids. And the young kids are the ones who carry the pneumococcus in the back of their throat. This vaccine, this new conjugate vaccine, got rid of that pneumococcus. Not only did it help keep kids from getting ear infections, pneumonia, blood infections, and meningitis, it kept their grandparents from getting pneumonias. And so once this vaccine was in widespread use, it actually helped decrease pneumococcal disease among all ages. So this is in 2002. You can see the vaccine schedules are now coming with footnotes. And this is only the vaccine schedule for kids up to 18 years with the footnotes up to 18 years. And this is for the ones who are on track. This is not the one that includes kids who are behind. In 2006, more footnotes. We added the meningococcal vaccine. And so we were talking a little bit earlier about meningitis due to meningococcus. And there are a lot of different types of meningococcus. And there's a new meningococcal vaccine against type B that I won't talk about tonight. I'm going to leave these vaccines for Dr. Irwin, since he's going to talk about the teen, and this is a teen vaccine because this was a teen illness. In 2007, suddenly it's so complicated that we have to split it up between the young kids up to 6 and the older kids. Rotavirus comes back. And so this is the vaccine that had been causing intussusception. After discovering that, they went back to the drawing board. The vaccine was re-engineered using a bovine rotavirus, and so a rotavirus that affects cows as the backbone, and a conjugate vaccine, or a manufactured vaccine as opposed to a live vaccine. This rotavirus vaccine is responsible for essentially closing the pediatrics unit ward at a lot of hospitals. There's a lot of data on the decrease in the number of kids with dehydration due to vomiting and diarrhea from this virus, and you can draw a direct correlation between the rates of vaccination and the rates of hospitalization for dehydration. The human papillomavirus vaccine was also introduced in 2007, initially only for girls to prevent cervical cancer. Again, I'm going to let Dr. Irwin talk about that one. He'll have lots of details for us. In 2011, the influenza vaccine was recommended for everyone as opposed to just high-risk groups. In 2012, the HPV vaccine was recommended for boys as well as girls. And then in 2018, you can see this is the current state. I didn't put the footnotes up here because they are formidable. There are pages and pages and pages of footnotes, but you can see comparing our vaccine schedule now and how many vaccines there are compared to where we started back in 1940s. We've come a long way, and we've protected a lot of kids and prevented a lot of disease. I'm happy to take questions, but I know I'm also happy to pass on. Yeah.
In the ER, we started giving DT, diphtheria and tetanus,
Yeah.
because what, diphtheria doesn't last 10 years or something? Or?
Yeah, well, the tetanus is what you need protection against, and so the history of the tetanus pertussis vaccine is that initially we would give DTP, so diphtheria, tetanus, and pertussis, and then as an adult, because the whooping cough or the pertussis was very reactive and caused a lot of side effects, we would give just the tetanus portion of that. In kids, sometimes we'd give the DT, the diphtheria, tetanus, if we were worried that there was a neurologic condition that the pertussis might be affecting. That vaccine switched in children to a DTAP, an acellular pertussis, where instead of taking the whole pertussis bacteria and making that into the vaccine, a few of the antigens were chosen, so a few proteins that gave you protection against the disease. That's what we use in children. In adults, for a while, we still just did tetanus and didn't protect them against whooping cough until we developed a Tdap. So tetanus, diphtheria, and pertussis. That's one vaccine where capitalization really matters. And so if you look in tiny little letters right down there, it's a big T because it has a lot of tetanus. It's a little D for a little bit of diphtheria and a little P for a little bit of pertussis, because too much pertussis gives you lots of side effects. And so in adults, that's the vaccine we use. Right now, the recommendation is for 1 dose of Tdap in your life unless you get pregnant. And if you get pregnant, then you get it with every pregnancy. And the reason for that is that we don't yet have data on whether doing it over and over again actually helps decrease pertussis in the population. But we do know that if we give a mom a Tdap while she's pregnant, she'll make antibodies against whooping cough, and those will transfer to her baby and protect the baby during the first 6 months until the baby makes their own. And so during pregnancy, every pregnancy, women will get the Tdap, but even those of us who hang out with kids with whooping cough, a formal recommendation is really just to get one.
Describe diphtheria. I've never seen a case, never heard of a case.
Yeah, neither have I. Diphtheria it affects basically every mucous membrane, and so it's a coughing pharyngitis. It's a nasopharyngitis, right? So it causes these what are called pseudomembranes in the throat. So I've heard. Fortunately, I've never seen the case.
I've seen diphtheria
Yeah.
in Haiti. So it causes, it's a bacteria that secretes a toxin that causes a particular type of inflammatory response that actually causes membranes. It tricks the cells of your airway into sort of forming membranes that are actually your own tissue that have a blood supply and everything. These pseudomembranes that can actually grow across the airway and completely obscure your airway and cause suffocation.
There you go, from the source.
I've seen one case of tetanus in the
Mm-hmm.
it was pretty easy to diagnose. Patient's chief complaint, I have tetanus. He got on the internet after his doctor said, his muscle spasm from playing golf. He was admitted, treated for tetanus.
Got better. Bravo. Should have been vaccinated.
Does pertussis have another name?
Whooping cough.
Whooping cough.
I
Yeah.
don't mean pertussis, I mean diphtheria.
Corynebacterium? Diphtheria, right?
No,
Isn't
no,
that
but
the-
I mean,
that's
there another name
I'm not
for
sure it
it.
has a different name than
Like
diphtheria.
tetanus is lockjaw.
right.
They
No.
don't have,
No.
I mean, you read accounts of children dying from diphtheria in the turn of the century, the last century,
Yeah.
and it was called diphtheria.
Yeah. Great.
For all you doctors who are in here, I'm the daughter of a pediatrician, and my dad's office was in our house, which is unheard of. And he used to make me kiss his patients to get
Oh.
the measles,
Yeah.
which naturally being the child I am, I never got. And then recently, believe it or not, on Facebook, somebody wrote something about we were having a high school reunion. She's like, wait a minute, didn't you live here? And I was like, yeah. She goes, your father brought me up to your room, so and I had to kiss you. And I'm thinking, oh my God, it was true.
Mm-hmm. Yeah.
But I got tested like 10 years ago or something to see which measles that I maybe have immunities to or something.
Yeah.
But I think that, I also never got sick as a kid until I went to college, because I was away. So I'm convinced that there were some immunities or something going on.
Kiss different people.
Some good
Because
humors,
they
yeah.
don't, right?
There is I mean, chickenpox parties were a thing, and when there was one kid with chickenpox in the community, everyone would come so that their kids would get chickenpox. Because that's so much less common now, for a few years ago, some of the folks who preferred natural immunity over vaccination were sending chickenpox infected lollipops through the mail. And so there was a Facebook group where you could order your lollipop so that your kid would get chicken pox.
That's considered a more natural way of getting chicken?
It's, it's a good way to make your child susceptible to shingles, and illegal to send an
More
infectious
natural way of
disease.
immunity.
I think the first biological warfare was when the U.S. government gave a lot of
Smallpox.
Native Americans smallpox and
Yeah.
blankets.
I don't know if it was the first, but it was very effective. Yeah, I could go on.
Are you guys going to be talking about shingles at all?
I am not, because I don't take care of a lot of kids with shingles, but I can tell you that that is one of the new adult vaccines. It's basically the Varicella vaccine that we give kids, tripled or quadrupled, right? Because as adults, we need a little more of a nudge to our immune system. And so it's the same vaccine, but at a much higher dose.
Yeah, I just heard there was like a new one again, like another new one.
Yeah, I think
Also
they.
advertised on TV. Ask your doctor.
Well, when are you ever going to go to the doctor unless you're told to, Hank? Thanks.
So I saw many of the diseases that you never saw because I'm older than you are. And I can remember going to the emergency room when I was in training and tapping so many young people, children. And I'll never forget the case that I had, which this boy came in, his father was a dentist, and the nurse said, I said, this kid has Haemophilus influenza, let's get a line in him and let's give him medication. The nurse said to me, that's not the protocol, Dr. Irwin. We have to tap the young person first. I said, we're going to tap him after we get the antibiotic into him because I know what he's got. And if he doesn't have it, it'll still be okay. That young person, 6-year-old, walked out of the hospital 7 days later. And then I became familiar with the legal system because we had to do a cut down in this young man, this boy. And as you might expect, he was quite dehydrated, so we had to really do an excessive cut down to get a line into him. And his parents ended up suing the hospital because as an intern, I didn't write a note informing the family that this was a possibility of complications. So he had to have plastic surgery on his arm about a year later. The interesting part of this story is that if he had died of H. flu, it would have not been a malpractice suit against the university, which I've always felt that this is the issue of forcing us to document things rather than taking care of patients, in a sense. I also saw a lot of cases of meningitis when I was in training, also meningococcal disease, which I don't think my concern is that none of our pediatric residents right now ever have any experience seeing infectious disease. So when we have a case, we have a showing almost of it because it's such an unusual experience for them. So in a sense, they don't know how to really make these diagnoses anymore because they don't have experience. So I consider myself a pediatric gerontologist because I take care of teenagers and young adults. I start seeing patients when they're about 12 years of age, and our practice now goes up to 25. Because we have so many young people that we take care of with chronic illnesses, and essentially they have few places to go to see, so we care for young people up through their 25th birthday. I'm not speaking for the pharmaceutical company or anybody, so I want to make certain, because we're talking about vaccines, that everyone knows I don't have any relationships with any vaccines companies. And I think taking care of adolescents there's lots of issues because, first of all, they rarely come to see physicians. They engage in behaviors that put them at risk for acquiring all these infections. They still need consent from their parents to get vaccines, and they don't always tell you about all the things they're doing. So let me kind of run through a few things, and maybe some of this will be covered. You've covered everything that much of what I'm going to talk about, so we can shorten my talk a bit. I think talk about the whole issue of public health. And in the 20th century, at the beginning, of this, the 20th century, the morbidity from all of these diseases that you talked about was incredibly high. But now we rarely see these diseases in the United States. You're more likely to see these diseases in third world countries. And they're the most cost-effective clinical preventative service that we have. They really provide a high return on our investment, saving many lives, reducing healthcare costs, and saving a lot of money for the world. Let me talk about the adolescent recommended vaccines. You've really covered most of them. So the current regimen for adolescents, there's a lot of people that talk about a 12-year-old platform. So right around 10 or 12 years old, there's a whole group of vaccines that we need to give young people. And now people are also talking about a 16-year-old platform, and I'll kind of run through this. But Dr. Branco's already told us about flu influenza, Tdap, HPV, meningococcal vaccine, both the ACWY and then the meningococcal B vaccine, which has just come on to the regimen for them, hepatitis A and B, inactivated polio, MMWR, and varicella. You already seen this from Dr. Branco. So what I'm going to do is just kind of march you through the various vaccines that are recommended for adolescents and young adults. So the meningococcal vaccine, which is A, C, W, and Y, so those are 5 serogroups. And we begin that first dose at 11 or 12, and then we give the second dose at 16 years of age. The other vaccine that's come on is meningococcal B. It was approved in 2015. It's a little bit different in terms of the recommendation. It's somewhat confusing. It's confusing for physicians. It's confusing for parents. It's confusing for young people. It's the meningococcal disease that really had the outbreak in Princeton. Maybe you heard about this about 7 or 8 years ago. There was a big outbreak in Princeton. There was an outbreak in Oregon this past year. There's been an outbreak in Santa Clara County. There's been an outbreak at Santa Barbara. And I think what's interesting is the outbreak in Princeton was almost like a natural experiment because all of those young people at Princeton had received the meningococcal ACWY. So in a sense, we kind of know that the serotype that they had was the meningococcal B, and none of them were immunized. So this vaccine came on board in 2015, and it's recommended for people that are living in labs where they're dealing with meningococcal serotypes. And it's also, then the other thing that it's recommended for is if physicians or clinicians think that the patients they care for may be at increased risk. And so it's not an absolute recommendation. It's kind of, we have these recommendations that category A, category B. So this is a kind of category B recommendation. It's up to the physician. In our practice, we are actually really giving this vaccine. We give it the first dose at 16. There's 2 types, 2 brands. One, you can give it the first dose at 16, and then you give the second dose a month later. The other one requires a first dose, and then another dose 6 months later. Then influenza, you've already mentioned that. In fact, this is a really hard vaccine. It's one of the vaccines that very few young adults get and very few adolescents get. It seems that we run into more families that don't want to give their children this vaccine, and they tell us, well, I had the flu last year and I had the vaccine, so I don't really want to take it. So we have more trouble getting this vaccine in our teenage patients. Then Tdap, you've actually outlined that, so we're not going to deal with that. And then the HPV vaccine is kind of I kind of call it the adolescent vaccine because it's essentially the vaccine that really brought vaccines into our practice in 2006. So it was approved in 2006 for girls. It wasn't approved for males in 2011. And everyone always says to me, how come it took so long to get it for males? Well, we live in a country where you can't actually give a vaccine unless it's met the FDA requirements. And the FDA requirements were that this vaccine needed to be tested in males before we could give it to them. every other country, once they approved the vaccine for females, it actually was approved for males without those studies going on. So people got really confused. I found we ran into a lot of problems in our practice with this HPV vaccine when it came on board, because so many women knew about this vaccine. There was such great press on, everybody knew about human papillomavirus, and they had never known about it before. And a lot of mothers would say to us, well, I don't really want to give it to my daughter. You know, my son was here last week, and he's 2 years older than my daughter, and I don't get it. Why isn't he getting it? And so I'd have to go through this lengthy explanation. Well, wasn't approved. We could give it off-label if you wanted to give it to your son, but you're probably going to have to pay for it, et cetera, et cetera. So it was a really, we had lots of discussion. One time, a colleague of mine on the East Coast, she says that when her patients come in at Yale's adolescent medicine program, the mothers will often say, well, you know, my daughter's not having sex right now, and I don't see why, and I should give it to her. And we have such a good relationship, there's no reason to give it. So she oftentimes says to the parents, I'm glad you have this great relationship. Let me tell you what you should do. Why don't you have your daughter tell you when she's going to have sex in a year? And then when she tells you she's going to have sex in a year, bring her in, because then we can start it, because we've got to get this vaccine into her before she's exposed to the virus. So she said that's a good way to get it in. One of the things about this vaccine, both hepatitis B and HPV vaccine can be given, actually children 12 years of age and older can consent for this vaccine if they want to. It's covered under the kind of actually sexually transmitted infections under the California state laws. So you could theoretically give it to a 12-year-old or a 13-year-old or a 15-year-old without parental permission. The problem we have with doing that in our practice is parents will see it on their FOB, when the report that comes to them regarding what their child got when they came to see us, and so they'll say, well, you didn't get my approval to give it. What's going on here? I want to just kind of run through some of what's happened since we've introduced HPV vaccine, because we have some really good information. So this is from the NHANES study, and this is from where they actually did HPV prevalence for females aged 14 to 24 by age group and time period. And so we see 14 to 19-year-olds, 20 to 24-year-olds. So these 14 to 19, the light blue is the 2003-2006 group. So you can see in 2009 and 2012, the HPV prevalence rates really dropped dramatically. And we assume, we don't know this for certain, that this must be due to these young people having gotten the vaccine. So what about this vaccine? What about this HPV? It's one of the, it's the second cancer vaccine. If you look at cervix, if you look at anal, if you look at vulva, vaginal, penile, oral, these basically are heavily weighted towards HPV. And so this really is a vaccine that you want to get into people. The one thing that I didn't talk about in that slide, let me just go back to this one for a second. This vaccine has undergone some changes over time. It was brought out initially as a bivalent vaccine, so it had 2 oncogenic strains in it, or a quadrivalent, which had 4 in it. And now the new vaccine, which came out in 2015, has 9 valent types in it. So it pretty much covers all the oncologic types. So it's a better vaccine than the vaccine was early on. Parents oftentimes come to us and say, well, my daughter or son got the quadrivalent vaccine. Should I get the 9-valent vaccine? There's not any really good data on whether they should or shouldn't. We generally say they don't necessarily have to get it, but if some parents want it, we've given it to them. It's not clear whether insurance companies will pay for it if they've already gotten the quadrivalent vaccine. So this vaccine is really important. There's a lot of people who become infected with HPV. Since the introduction of this vaccine, we've had a decrease in HPV infections in girls by 56%. Some of the longitudinal studies on women that have been vaccinated with this, it's really long-lasting and it's safe. There's very few side effects. There's some syncopal episodes that have been recorded in girls having this vaccine. We just published a paper, we didn't, but I edited the Journal of Adolescent Health, and then recently an article came out in that journal that really, when you look at syncopal episodes, it really is probably not related to this vaccine. But initially, we were supposed to keep girls in our practice for 15 minutes lying down because they might pass out. So the other thing that I want to just say why this vaccine is so important is if you look at the sexual activity rates, and if you look at where you start getting this is where we're recommending that girls start on this HPV vaccine. You can see why we want to get it here, both girls and boys, because essentially there's this really upswing. So you definitely want to get it into them before they're 13 or 14 years of age. Even though your son or daughter may not ever have sex, it really is important that we get these young people immunized early. There's also a benefit for getting young people immunized before 15, because if you get them immunized before 15, they only have to have 2 immunizations. After 15, they need to get 3 immunizations. Everybody says to me, why is that? It turns out that younger kids have a bigger immune response, so they get higher levels of immunity when it's given early. And as they get older, our immune system, already their immune system is changing, so that's why you want to get it early. So the other thing is, people forget that there's more than just vaginal intercourse and anal intercourse. There's lots of young people that engage in oral sex, and so the issue is just because, and some people engage in oral sex instead of vaginal or anal intercourse. So it's really important that we not forget that young people may not be engaging in intercourse, but engaging in oral sex. And so there's reasons for getting this vaccine in them. So let me talk about the vaccine coverage. The story is interesting. We're pretty good at getting Tdap. We're really good at getting the first dose of the meningococcal vaccine. But as you see with these vaccines that need 2 or 3 doses, it rapidly drops off. So we see that only about 33% of kids got the 2 doses of meningococcal vaccine, the ACWY. Only about 42% of girls got at least 3 doses. And then for boys do much worse than girls. And then for the influenza vaccine, it's only about 47%. If you look at young adults in terms of flu vaccine, about 20% of young adults get flu vaccine. So they're the lowest rate of any group in the country. So I think that the gaps in immunization rates, vaccination rates for Tdap and the first dose of meningococcal are really great, but the rates fall off quickly. And 67% of eligible adolescents are not fully immunized during a critical risk period for meningococcal disease. And then adolescents and young adults ages 15, 20, 24 make up about 20% of the 2,000 deaths that occur from meningococcal disease. So if you think about it, that's a pretty big chunk of young people dying from meningococcal disease, which probably could be prevented if they were fully immunized. The other thing that I found interesting, I wanted to just look at influenza deaths. So adolescents made up a quarter of the pediatric deaths from influenza between 2014 and 16. Half of the 14 million new HPV infections that occur each year in the US occur among this 15 to 24. And more than half of parents of boys and 1/3 of the parents of girls reported they had not received HPV recommendations from their child's provider. And the most effective way to get uptake of the HPV vaccine is to have a physician who gives a really strong recommendation to the parents on how important it is. There's some really good data out that that's the most important thing that clinicians can do in their practice. So why aren't adolescence rates higher? You know, it's some of it is parents really might not understand. I'm always surprised at how many parents don't really think that preventative care for their adolescents is important. There's a couple of studies out now that most parents of adolescents say, well, they'll come to you go to the doctor when your child's sick. You know, you don't go for well care. You did that when they were a small child, but you don't need to do it when they're a teenager. And in national data, about half of a medical expenditure panel survey, we've actually published this work, only about half of adolescents actually got in for a well visit in 2012-14. That's even after the Affordable Care Act was introduced, so more people were getting well care. And only about a third of young adults ever make it in for any kind of well care. So I think I'm not certain if parents or adolescents and providers, I think, may view immunizations as less important. They may view the usual AYA issues such as sex, drugs, rock and roll, but all of those issues are highly associated with infectious disease, so we got to kind of add immunizations as being really important for them. And the care for immunizations is not necessarily as routinized for children. So thought I'd just maybe you're going to cover some of this, so I don't want to. But despite this wide spread availability of vaccinations, there's been really multiple resurgences in vaccine preventable diseases since the 80s. And I think some of the resurgences have been due to families kind of refusing to vaccinate their children. Since many of these vaccines need more than one dose, so it's if you change practices, how do you follow whether your son or daughter or the clinician knows what you've already gotten? There's kind of waning immunity we now see as we follow adolescents, and this really vaccine hesitancy, which really has been a hallmark of some of the issues in Marin County. So these are the kind of immunization rates for adolescents. What I've done here is pull out the U.S. rates in 2015 and compared them with the California rates. The U.S. is in that, I guess, orangey one and green. So it appears that U.S. generally does better. Overall, U.S. rates do better than California. And the ones that we're not doing as well on here, but we're doing a little bit better in terms of HPV in California, where about half of our girls look like they're getting at least 3 doses, and about 30% of our males are getting 3 doses. This slide I put up here because I think it's interesting. So the blue line is US, this green line is California, and this is vaccine preventable childhood diseases lumped all together by disease in the United States. And as you can see in California here in 2014, we're at about 30%. And here throughout the United States, we're about 18%. So you can see that in California, we're not doing as well probably in getting our immunizations into our children. Are you going to talk about these things like recent outbreaks of measles? Because I won't. Okay. So Dr. Franco also already said that it was declared eliminated in 2000, and then there was a record number of measles outbreak cases in 2014, with 23 outbreaks and 644 cases across 27 states. And then in 2015, we saw the largest multi-state measles outbreak that was thought to originate with an overseas traveler who visited Disneyland in California. We already heard this. And the majority of people contracting this disease were unvaccinated, so we had a natural experiment. So this slide shows you that it was more scary than the haunted house. And again, mumps, we talked about that about 6,000 cases were reported in 2006, and this was the largest U.S. outbreak in 2 decades, and it occurred mostly in the Midwestern states and colleges, as we've already heard. So I think, there's a couple of issues about improving compliance. I think that increasing community demand for vaccinations, so essentially families and the community demand that people are immunized, and we're doing better at that, I think, in California now. Enhancing access to vaccination services. I think with adolescents and young adults, we maybe need to stop thinking about the well visit as a way to get vaccines in, and we probably need to give vaccines whenever we see them. So if they're there for a sick visit, we need to give them a vaccine. If they're in the ER, maybe we should be giving them vaccines in the ER. Maybe if they have a chronic illness and are being followed by subspecialists, maybe subspecialists could be bringing vaccines into their office. But I think to rely on well care may not be the best opportunity. I'm certain Dr. Branco says that in his practice they do really a great job. So maybe a community-based practice or a physician-based practice where you really know your patients really well, you're doing well. But I'm always surprised when we looked at our rates last year of HPV uptake in an adolescent medicine practice, we were less than 50% for getting 2 or 3 vaccines, and we're like continuous chanting about HPV. So even when we show that to our physicians, they say, "Oh, that couldn't be." And I said, "Well, it's what it is." So, and I think provider-based interventions really, and I think continuous quality improvement projects where you see what's happening in your practice is really a great way to move forward. So this just kind of looks at this immunization platform that has just come out through an immunization initiative to really try to ramp up vaccines in this older age group and really establish a platform for the 16-year-old to try to do catch-up vaccines, to get that meningococcal vaccine into them, to initiate the meningococcal B vaccine, and to make certain that they've gotten coverage for HPV. And this is, anyone's more than willing, if someone wants this material, certainly I can provide it to them. But this is a pretty good handout that is from this adolescent immunization initiative, in which it lays out and might be a good handout for people to have in their practice. And I'll end. Thank you.
Vaccination rates in Marin County have increased from 78% 5 years ago to 94% today. That was partly because of the efforts we've made here in the county to inform people about the value of vaccinations. We've seen decreases in many of our vaccine-preventable diseases, but we're seeing rates of pertussis that are higher than others, than other years. And we know that we expect cyclical increase in pertussis every 3 or 4 years just by nature of the disease itself. But one question I'd like to bring to you, Nelson, and Dr. Irwin, is in the setting of increased vaccination rates, how do we explain increase in pertussis rates?
I think they're
Turn your... And I think that this question is in the spirit of the way in which we've been approaching our vaccine debate and dialogue. I wouldn't, what some people call a vaccine debate, which I think is really just a conversation about the effectiveness of vaccines, but really looking at the entire picture as honestly as we can. So,
yeah. I think there are a few things that come to mind. The first is that our vaccine is not 100% effective. We know that no vaccine is 100% effective. The acellular pertussis seems to be a little less effective than the old side effect-ridden whole cell pertussis.
mm-hmm.
The other is that we are testing for pertussis far more than we ever did,
Mm-hmm.
and we're testing for pertussis in a much more specific way, in a much more sensitive way, I should say. And so we have a new test called the PCR test, which is very sensitive at picking up pertussis, so much so that when I do a PCR test, I need to be careful not to do the test in the same place where a pertussis vaccine is being prepared, because it will pick up the proteins from the pertussis vaccine and turn positive when it's not positive. And so, more testing, a better test, a vaccine that may not be as effective. And then the third is that I don't think that our increased rates of vaccination are really increased rates of pertussis vaccine. When there was more vaccine hesitancy and more of anti-vaccine or folks who were deferring vaccines, the MMR and the hepatitis B were the two big culprits. Other vaccines were refused or delayed or deferred at much lower rates. And tetanus, and of course because tetanus comes as part of the DTP, has always been a favorite of even folks who are staunchly opposed to vaccines. And so I don't think that our rates of pertussis vaccination have changed all that much, despite the fact that we have much better rates of other vaccines.
Okay.
My theory.
Thank you. Do you have anything to add to that? Yeah. So we have, I would add to that Marin County has historically had high pertussis rates. Back in 2010, when we had the statewide outbreak in pertussis, where there was 10 infants that died from the disease, Marin County had the highest rates of any county. And there's been an extraordinary vigilance around awareness of and diagnosis of pertussis across the county. Obviously combined with more sensitive testing, I think we're more confident that even those marginally, not all that ill high schoolers who are coming in for testing are actually getting tested and getting diagnosed with pertussis. We know that by virtue of having been vaccinated, those children will have less severe disease and a disease of shorter duration, even if they are being tested and registered as a case. Okay, yep.
Is there any data on testing rates?
We don't have comparative data on testing rates. Yeah, we'd have to go to the laboratories for that, and we're looking at trying to do that. So I'm going to, yeah.
Can I just on that same token, while you're on that topic, how can, if part of the reason for this increase is because of increased testing, on that same token, how can you say that there has been an uptick? Do you know what I mean? If we're
Right.
talking about a fivefold spike, but you're saying it's because of testing to refuse the fact that there's a big increase,
Is there more testing this year than last year? Like, how could we say, right?
Right, so I'm just saying, is that a real uptick, or is it because of more testing?
I think when we talk about an uptick, what we always say there's an uptick in documented disease. I think we all recognize that before we had increased awareness of pertussis, there were a lot of adults with bronchitis who would get treated with Zithromax, who were being effectively treated for the whooping cough that they had, but nobody called whooping cough. And now it's being called whooping cough because even the physicians who take care of adults are aware of whooping cough and how dangerous it can be to infants, and so they're testing. And so that's why I think testing rates would be interesting, because I'll bet that there's just as much pertussis other places, but if they're not looking for it, they're not finding it, they're calling it bronchitis or pneumonia or other things.
And it may be, some of this may be our fault, my fault. I mean, because we've been, putting out public health advisories around pertussis incidents and encouraging our prescribers to think pertussis when patients come in with symptoms consistent with pertussis, chronic cough, et cetera, in order to protect the young people. Yeah. So
and parents come in asking for pertussis testing. I mean, they show up in my office when there's a case at the school, my child has a cough that's clearly a cold. And they request pertussis testing, and often it's reasonable to do, but that's new, that's unusual.
Do you want to speak to when the PCR became available and how the old test was maybe not as performed because of the delay in getting the results back?
Yeah, I mean, I can talk about my 20-year career, right? The early part of my career, like yours, it was, we would do a blood count and look for findings on the blood count because the pertussis culture took a week or two to do, and so by the time you got the results, it wasn't useful. And then we had the DFA, the direct fluorescent antigen test, which was 60 or 70% sensitive, and so you'd miss, a third of the cases with that test, but it did come back within a day or two, so within the right amount of time. PCR has really been the last 5 years, I think, that has been widely available and easily available, and so I think that coincides with, not only some of the vaccine talk and the fears that low vaccine rates may lead to increased rates of pertussis, but then some of these outbreaks.
And we'd rather be diagnosing and treating pertussis in teenagers. We haven't had any cases in infants. You had 0 pertussis in Marin County infants, and that's really that's our goal. That's a success by our measure. All right, I'm going to just I know that we've had a rich discussion thus far.
When you have a case of documented pertussis, does that then immunize them for the future, or do you immunize them or those families now, or
When we have a case of
diagnose of documented?
absolutely, yeah. If there's pertussis in the household, we try and make sure that everyone in that household is protected prophylactically with antibiotics.
Do the people who are infected have ongoing protections from that? Do they get
Yeah.
It wanes. It wanes after 3 years or so. It's not like lifelong immunity the way it is for other diseases. Thanks for that opportunity, because the media was here and they were asking this seeming paradox. If you're claiming a success in your vaccination rates, but at the same time you're saying you have 5-fold higher incidence of pertussis this year, how do those things fit together? And there's a chiropractor down the street who's eager to point out that it must mean that there's no value to vaccination. Right. So I think we've heard enough about the sort of historical picture and the value of vaccinations over time. This basically shows different diseases that are vaccine preventable and how their incidence has decreased after the introduction of vaccination. For example, polio. Incidence here in 1950 peaked, and then the vaccine was discovered, and immediately after the vaccine is discovered, we see precipitous declines in the incidence of the disease. Our memories are short. This is just the 1950s. This is an iron lung ward in California. Nelson just mentioned that one of the last people of this cohort is having trouble finding parts for their iron lung machine. Still alive. Imagine living your entire life in a machine that's breathing for you because your diaphragm has been paralyzed by this virus. This is Marin County, 1964. So the Marin County Library keeps an archive of old stories, and we were actually able to get pictures from 1964. These are people lining up. That looks like it might be Wade Thomas School. KO Polio, knockout. Is the slogan for the day. Knockout Polio Day, right? September 1964. People lined up all over the state and in Marin to get their vaccine, and this was here in Marin. 128,000 residents on the same day. So this was massive campaign. Were you part of that? You were one of the. Maybe you're in this picture. Someone brought their dog, and this was the sugar cubes. Yeah. So here are kids lining up, getting their. Maybe you're one of these guys, right, back then. And it turns out Jonas Salk is actually a friend of my son's in 8th grade, and his grandfather is Jonas Salk, Marin County. So polio eradication, this was the effect of having this vaccine more widely available. In 1988, these are the countries in dark where polio was endemic. And in 2006, it was down to parts of Southeast Asia and Nigeria, and in an interesting phenomenon that Nelson mentioned, there's Boko Haram and some of the other militant groups are sort of politicizing and using polio eradication campaigns as a tool for perpetuating their terror in their own areas, and they're actually making it really difficult for the World Health Organization and the CDC and others to actually complete the eradication efforts by reaching out and causing problems with people who are actually trying to vaccinate those last clusters of polio. This was one of the ironies of my career as a health officer. I had been working at the CDC before I came to Marin County, doing international disease control. I was in Haiti after the earthquake, working on the surveillance system for outbreaks in the tent camps, and we were seeing vaccine-preventable diseases like diphtheria. And I came to Marin County, which is the opposite end of the socioeconomic spectrum, and turns out we were at risk for the same problems, but for a very different reason. And so I, it was pretty clear that we wanted to prioritize, as a health department, prioritize addressing low vaccination rates. This is the trend we had been seeing up until about 2012. That upper line is the number of parents, the percent of parents in Marin County that were opting out of vaccines with personal belief exemptions. The law in the state of California at that time allowed for parents to opt out of required childhood vaccinations. So this is a law that required parents to vaccinate their children against vaccine-preventable diseases, except that there was a clause in that law that said, unless you disagree. And then you sign this and you don't have to get vaccinated. So I'm just thinking, what other public safety or what other law can you just choose to opt out of? Stop signs, red lights, sorry officer, I don't believe in stopping at a stop sign. And essentially that's what it was. The law was in place for a good reason, but people were able to opt out, and it happened more and more frequently in Marin, which brought some national attention to us. And John Stewart said that we are more afraid of measles than we were of, we were more afraid of gluten than we were of smallpox. That was his line. And there was National Public Radio and others who came to actually talk to us about what was happening in Marin County, of this paradox of highly educated but low vaccinated population. There was an assembly bill that went into effect on 2109. I'm just going to spend a little time talking about the policy environment here. So 2109 was a law that required that parents, in order to obtain a personal belief exemption, had to have at least have a conversation with a pediatrician. And to me, this was a great example of validating the relationship of a pediatrician in a family's life and in a child's life. Because what we found was that vaccination rates increased in Marin County significantly after that law went into effect because of the conversations that were happening. And in Marin, it was partly because we had one of the most dramatic increases in vaccination rates in the 2 years following AB 2109, partly because we had worked together to sort of have better informed conversations with our parents. And this was a survey that we did in conjunction with the Marin County Office of Education around specific vaccination beliefs. I'm just going to go quickly through. So we had about 500 respondents. We sent a survey out to kindergarten parents in Marin County and asked them what are their beliefs around vaccinations. If they're choosing to opt out, why? It was a mystery to many of us on the sort of medical science side. Why would someone choose not to vaccinate their children? And what we found was that there were some important differences in where people were getting their information between those that had sought to exempt themselves from vaccinations versus those that hadn't. And we found that more, not surprisingly, people with personal belief exemptions were getting their medical information from complementary and alternative providers rather than physicians or other licensed providers. And they were also more frequently getting their information from health-related websites versus a licensed physician. I won't go into this in detail, but basically what this showed also was, importantly, that there was actually a wide range of different vaccines that people who were getting personal belief exemptions were opting out of, as Nelson mentioned. So some were opting out of the Pertussis vaccine, some were opting out of the measles vaccine, some were opting out of hepatitis B. The most common, as was mentioned, 64% of our parents who were opting out of taking personal belief exemptions were actually up to date with the Pertussis vaccine, the diphtheria, tetanus, and Pertussis vaccine. Whereas chickenpox and hepatitis B, very low rates of uptake for those. So I had come into this sort of assuming that these are anti-vax. People just don't believe in vaccination. And that's actually not the case. Most of our parents who are obtaining personal belief exemptions believed in vaccination, but just were picking and choosing which vaccine to accept, which was important insight, because approaching someone who actually believes in vaccination and is choosing to vaccinate their child and just educating them specifically about one disease or another is a lot different than trying to educate someone about why we vaccinate in the first place. which I think was a tactical error we had made before, which was actually talking about the value of vaccination as a principle to people that already believed it. They were just choosing to opt out of one or another. Is that right? So what we found was these are the beliefs that people were citing when they were choosing to opt out of vaccines. Too many vaccines at the same time. I'm uneasy with newer vaccines. Vaccine contain unsafe toxins. Surprisingly, about half of them thought that vaccines, they weren't sure whether vaccines can cause autism. They can cause the disease they're supposed to protect against. And it's not necessary because the diseases aren't as common anymore. That was particularly true for polio. These are the other reasons they cited: preferring natural immunity over immunity conferred by vaccines, children are at low risk, and lack of trust of the healthcare system and pharmaceutical industry. I'm not going to go through each of these. We can, discuss this, but basically the process was interesting, is that for each of those kinds of concerns that parents raised, we had conversations with our pediatricians, and I think Nelson and Dr. Levitt were part of those, in terms of how do you communicate with your patients? What do you find effective? And we basically compiled sort of a library of talking points that we were able to offer pediatricians across the community to help them in their communication with concerned parents around some of these common themes. And and basically this slide set that I'm presenting here is something that we were actually able to take to some of the pediatric groups to help talk about how might you address some of these concerns that we know your patients have here in Marin County based on our survey results. Low perceived risk, this is an important point. In the age of globalization, even diseases that are rare in the US are just a plane ride away. So that notion that just because we don't have a lot of incidents here, in a global, especially with Marin County, people do a lot of traveling, it's just a plane ride away. And then the alternative schedule. This was a talking point, I think, that came to us from, might have been Dr. Branco, around delaying. So we found a lot of our patients are choosing to delay their vaccine. So I don't want to get them all at once. You're asking me to get 5 today. We'll do 1 today. I want to do another one a month from now, and then another, and this very long, delayed schedule. The message that was suggested to address that was, if you're going on a journey with your child, would you choose to put your child in the seatbelt in the driveway and begin your journey, or would you put the child unrestrained in your car and then drive 3 miles down the road or 10 miles down the road and then put them in the seatbelt? Why would you choose to put them at that risk for that interval? And these are the kinds of things that we were actually able to sort of hone in terms of our messaging. And what we found is, the implications of it, that we knew that not all Marin County parents were receiving vaccination from licensed providers. That law, AB 2109, that actually prompted a necessary conversation with a pediatrician was important. We were able to anticipate parents' concerns, recognizing there's a diversity of vaccine decision making, and then framing as a community benefit was another important factor. People saw vaccination as a personal belief rather than something you would do for your community, and that was really kind of an important talking point for us, that this is a matter of community responsibility and not just individual choice. There was a lot of public dialogue on this, a lot of public debate and media coverage, and this was essentially the result. The punchline here is that we saw relatively dramatic increases in our vaccination rates in Marin County from 2012 to 2013. We had a low of around 78%. After AB 21 went into effect, we started seeing dramatic increases. And then SB 277, which is the new law now that has actually eliminated personal belief exemptions completely for incoming kindergartners and 7th graders. A lot of people will look at this, this law, SB 277, and say, well, now they've eliminated personal belief exemptions. Of course you're seeing more vaccinations. But in fact, what we know is that many of our parents were actually choosing to vaccinate their children at greater rates just based on conversations, new conversations with pediatricians. So this is all an era of choice up until that line there. So the most dramatic increases in vaccination rates in Marin County were actually due to new kinds of conversations and education.
It was my impression that the acceptability of vaccination was very strong until this idiot came out with this idea and published it that vaccinations caused autism. And that's when people started generating their own beliefs about ways of getting out of doing it.
Yeah, so this was one of the, I think one of the tragedies of science is that there was a badly designed, falsified study that was published in 1998 that basically suggested there may be a relationship between the MMR vaccine and autism. And it turns out after that was released that there was all sorts of flaws in the methodology again, and there was actually falsification. All of the authors, except for the primary author, withdrew their names from the study. The study was actually withdrawn from the journal, and Wakefield, who was the author, has been, had his license revoked. But unfortunately, once that suggestion comes into the mind of the public, you can't pull it back. It's sort of like asking the jury to disregard a statement that's already been made. So the only way to refute that is to actually offer evidence to the contrary, right? And fortunately, we have more and more evidence that there's basically, however we look at this, there is no association between vaccines and autism. And we're up to over 20 scientific studies that have tried to answer this question and basically find that there's no association. Mercury is the one that people are most concerned about, and there was an interval of time where mercury was actually used as an adjuvant in vaccines. It is no longer, but there are other adjuvants that are used in vaccines that people are concerned about, and some of them are there for a good reason, including potentiating the value or the response, the immune response to the vaccine.
There's actually more aluminum in the breast milk that your child receives if you breastfeed them for a year than there is in the vaccines that you give them in the first year of life.
I noticed that was in the
Yeah.
messaging, whether we know that definitely perceptions were.
Yeah. It's what has happened over the years. So the mercury issue was thimerosal, which is a preservative that was in the vaccines and was removed in 1999, 2000 from all vaccines except multi-dose vials of influenza vaccines. We're fortunate in the U.S. that we get to remove a preservative and still have effective vaccines because we can use single-dose vials.
Mm-hmm.
You can't do that overseas.
Refrigeration.
And the reality is that we've seen no change in the rates of autism or any issues. The contrary, that getting thimerosal seems to be protective if you look at the statistics that way. The vaccine folks sort of move from one to the other. Right? So first it was MMR. The studies showed that MMR wasn't associated, so then it became thimerosal. The study showed thimerosal wasn't associated. Now it's aluminum. We'll have studies that show that the aluminum is not the issue, and they'll move on to, actually it was too many vaccines. Some studies that showed that wasn't associated, and then it moves on to aluminum, and there'll be something else.
One of the most important factors, I think, in this conversation was we had a child here in Marin County named Rhett Crowett who had leukemia, and he was not able to get vaccinated. And his father and he himself, who was 7 at the time, really sort of mounted a campaign to travel around, and they actually were up in Sacramento when SB 277 was being debated, basically saying, I have a right not to be exposed to a disease that could kill me. And your choice not to vaccinate your child is putting me at risk. And he'd stand up there, they'd put a little stool for him, and he'd say, I'm Rhett Crowett, and I give a damn, was his line. And it was incredibly effective because it put a face to this concept of herd immunity that otherwise is a relatively difficult epidemiologic concept. Say this child is actually at risk because of people's beliefs to opt out of vaccines. I'm just going to end with, again, this question that was, this kind of coverage and the fact that it raises people's concerns itself, I think, perpetuates this false notion that there may be risk. And I love having these conversations. I've learned so much from just hearing from Dr. Branco and Dr. Irwin. I think this is something that we're constantly trying to hone our messaging around. This conversation 3 years ago would have been full of, I think one of the fact that there's not a lot of people here tonight is actually a sign, I think, that some of these questions are relatively answered in some ways. This was a highly controversial topic for us not too long ago. But I think thanks to many of the conversations that have happened around the policy with SB 2109 and then SB 277, there's been a real chance for sort of the vetting, the societal vetting of some of these questions and some consensus and maybe some closure around some of these questions that had been really damaging doubts in terms of our risk for outbreaks. When the measles outbreak happened in 2015, we knew we were very vulnerable as a community because we had very low vaccination rates against measles. So we actually opened clinics, pop-up clinics, as a health department in different parts of Marin, especially areas where there are low vaccination rates. And that was not an uncommon phenomenon, where a young person would come with their reluctant parent to get vaccinated, and the parent would, made a good decision to say, well, he's old enough now, he wants to do this, it's not what I want for him, but he's made a decision that he wants to get vaccinated. And kudos to that parent for allowing the child to make the right decision. Any other questions? Thank you.
very much.
Thank you
Thanks.
so much.
Thank you.